One of the key questions with immunotherapy being integrated in lung cancer treatment is how they fit with the standard therapies that preceded them, whether that is conventional chemotherapy or in patients with a driver mutation in particular, alongside of targeted therapies that can have such significant activity. Should they be used sequentially? Should they be used concurrently? And really, as soon as these agents came into the market, really exploded into clear activity in the second line setting, there were a plethora of studies done combining them in previously treated patients, and now an increasing number of trials that are being completed and starting to have results reported for combinations even in the first line setting. I think we do need to separate out those with driver mutations who get very significant benefits very often from targeted therapies, the EGFR mutation positive with an activating mutation, ALK positive patients, ROS patients. These patients have a response rate of 60, 70, 80% and progression-free survival of 9 months, a year or longer. And so it's hard to improve on that. And thus far, it seems like many of those patients may not be the ones who benefit much from immunotherapy. And I would say that that group of patients should definitely not have their targeted therapy pushed aside for immunotherapy. It's even not clear that the combination adds much. We will see larger studies to answer that question. The bigger issue is about how to integrate chemotherapy and whether you should be giving many of these therapies concurrently as early as possible, or spread them out over time. When we have second line treatments available for everybody and first line monotherapy for some, is it better to give it monotherapy followed by chemo for the high PD-L1? Is it better to give chemo followed by immunotherapy for the low or no PD-L1 expression? These are questions that really need to be answered. We do have now a very recent approval for the combination of pembrolizumab with carbo and pemetrexed for non-squamous advanced disease, but that's based on a very small number of patients, and I would say that the vast majority of thought leaders would really like to see larger numbers and would like to see longer follow-up, ideally even see a survival benefit that's statistically and clinically significant, to know that it's better to give all these therapies up front rather than spread them sequentially, because that to me is not exactly precision medicine. That's just giving everything you've got right out of the gate.